Morning, children. Yesterday I was talking about carcinoma of prostate and disease of the penis. So, what are the pre-malignant lesions of the penis? So, yesterday I told that the pre-malignant lesions of the penis are Bowen's disease, Bovenot papulosis, and erythroplasia of Tourette. These three things are the pre-malignant lesions of the penis. So yesterday I also covered benign prostatic hyperplasia and carcinoma of the prostate. So carcinoma of the prostate is an important question. Benign prostatic hyperplasia is seen in elderly individuals. In the prostate there are two parts functionally. Based on the endocrine response, they are divided into two parts: the periurethral part and the subcapsular peripheral part. In the periurethral part, BPH, benign prostatic hyperplasia occurs. So when there is benign prostatic hyperplasia, it causes compression of the urethra, leading to difficulty in maturation. Whereas carcinoma of the prostate, it arises in the peripheral part of the prostate. So this does not cause frank urinary obstruction, but per rectal examination, this can be felt. So carcinoma of the prostate is a disease. It is the second most common malignancy in men. It is second leading cause of cancer. The first one is a lung cancer. The second one is a carcinoma of the prostate. It is usually seen greater than 50 years. About 50% of the men greater than 80 years, they have an asymptomatic carcinoma of the prostate. So many times carcinoma of the prostate is detected as microscopic fossa removed for the BPH. So for BPH, TURP is done, transurethral resection of prostate. So in these prostatic chips, this carcinoma of the prostate is detected incidentally. So basing on the how this was discovered, carcinoma, there are different types. Clinical carcinoma means on doing per rectal examination, this carcinoma is there is suspicion, and doing ultrasound, transrectal ultrasound, and on doing the biopsy of this prostate, then we can diagnose, we will come to know there is carcinoma of the prostate. That is called clinical carcinoma. So occult carcinoma means there are no clinical features, but they are present with some metastatic features. So the occult carcinoma means the carcinoma is silent clinically, but there is presence of metastasis. For these metastasis, we investigate and we can come to know that there is a carcinoma. That is called occult carcinoma. Incidental carcinoma means for a case of BPH, for some enlargement of the prostate, you have done BPH for urinary obstruction symptoms. We have done prostatectomy, and after doing the prostatectomy, we thought actually it was a BPH, but benign prostatic hyperplasia. But under the microscope, it turned out to be carcinoma of the prostate. That is called incidental carcinoma. Means clinically it was not discovered, but incidentally we came to know that there is a carcinoma of the prostate. Actually, it presented as a BPH, but on doing biopsy, we found out that there is underlying carcinoma. That is called incidental carcinoma. Latent carcinoma means a person died for some other reason. We had done the autopsy, and during autopsy we came to know that this person is having carcinoma of the prostate. So latent carcinoma, there are no clinical features. Death occurred because some other reason, and we on doing autopsy only we came to know that there is a carcinoma of the prostate. That is latent carcinoma. Incidental means we had done the operation, transurethral resection of prostate for BPH, and under the microscope, when we came to know that there is a carcinoma of the prostate. That is incidental carcinoma. Occult carcinoma means there are no clinical features, but there are some metastatic deposits. So on investigating further, we came to know that there is a carcinoma. That is called occult carcinoma. Clinical carcinoma means it presented with clinical features: urinary obstruction, hematuria, per rectal examination. There is a firm hard prostate on per rectal examination. In transrectal ultrasonography, there are some positive findings, and on biopsy, it shows prostatic carcinoma. That is clinical carcinoma. So, what is the etiology? So so during my PG, when we gave a prostatic for the TURP chips, we gave the report as carcinoma of the prostate. The next 2 days, we received the specimen of the testes of the same patient. So I thought, what these fellows, these people are doing for carcinoma of the prostate, they have removed the testes. In the testes, there is no involvement. So what is happening? I thought, but actually, the thing is, androgens are considered essential for the development and the maintenance of the prostatic epithelium. So the testis, when the testis is there, it produces androgens, which are responsible for the proliferation, development, and the maintenance of prostatic epithelium. So orchidectomy in a case of carcinoma of prostate, it causes arrest of the metastatic prostatic carcinoma, and because testis is the main source of testosterone. So administration of estrogens also causes regression of the prostatic carcinoma. So there is endocrinologic factor on orchidectomy. If you do the orchidectomy for a carcinoma of prostate, there is metastasis metastatic load does not develop, and the carcinoma of the prostate is extremely rare in eunuchs and Klinefelter syndrome patients because testosterone is very much low. So one is endocrinologic factor in case of carcinoma of prostate. There are racial influences. So American blacks and Americans have a higher incidence of carcinoma of prostate when compared with whites. So nodular hyperplasia, BPH, benign prostatic hyperplasia. This nodular hyperplasia is not a precursor of carcinoma of prostate, but these two diseases occur in the adults. So about 15 to 20% of the BPH cases, benign prostatic hyperplasia cases, there is a coexisting carcinoma of the prostate. Nodular hyperplasia is not a precursor, but both the diseases are seen in about 15 to 20% of the cases. Both diseases means nodular hyperplasia and carcinoma of the prostate are seen in the 15 to 20% of the prostates. So next one is a histiogenesis. And these lycopene, vitamin A, vitamin E, selenium, and soya products have a preventive role in the development of carcinoma of the prostate. So this prostate is androgen sensitive. That is why orchidectomy results in regression of the metastatic deposits. So histiogenesis. The prostatic carcinoma arises from a pre-malignant stage called PIN. PIN stands for Prostatic Intra Epithelial Neoplasia. PIN. The precursor for prostatic carcinoma is PIN. PIN stands for Prostatic Intra Epithelial Neoplasia. PIN refers to multiple foci of cytologically atypical luminal cells overhanging a diminished number of basal cells in the prostate ducts. So in PIN, the basal cells are decreased, and the epithelial cells which are towards the lumen, they show minimal atypia, pleomorphism, and hyperchromasia. So based on the atypia, cytological atypia, this PIN is of two types: low grade and high grade PIN. Low grade PIN stands for prostatic intraepithelial neoplasia. Low grade and high grade PIN. So grossly, the prostate is enlarged. It may be normal or smaller in size. In 95% of the cases, this prostatic carcinoma is present in the peripheral zone. More so, peripheral zone in the posterior lobe. In the posterior location is the most common. The carcinoma of the prostate, in 95% of the cases, it is present in the peripheral zone, more so in the posterior location. Carcinoma of the prostate, in 95% of the cases, is present in the peripheral zone, more so in the posterior location. So the cut section is firm and gritty. It is cut section is irregular, yellowish areas. The malignant prostate is firm and gritty. So basing on the microscopy, there are 4 types: adenocarcinoma of the prostate, transitional cell carcinoma, squamous cell carcinoma, and undifferentiated carcinoma. So about 96% of the cases, the carcinoma is adenocarcinoma. The rest are rare. So carcinoma of the prostate means 96% of the cases it is adenocarcinoma. Transitional cell carcinoma, squamous cell carcinoma, and undifferentiated carcinomas are rare. So about 96% of the cases are adenocarcinomas. So architecturally, microscopically, there is loss of intra. Normally, there is a gland. Glands with the intra-acinar papillary tufting is seen in the normal prostate. But in case of adenocarcinoma, there is loss of intra-acinar papillary convolutions. There is no intra-acinar papillary convolutions. There are groups of acini which are closely packed. Back-to-back arrangement of these acini is seen, or they may be haphazardly arranged. So back-to-back acini are there, back-to-back acini are there, or they may be haphazardly arranged. This is a microscopic picture. There is no intrapapillary tufting. Back-to-back acini or solid sheets of these cells is seen. So stroma is very little. The stroma is scanty, and the tumor cells penetrate the fibromuscular stroma. The stroma is scanty. Normally there is abundant fibrocollagenous stroma. Fibrocollagenous and smooth muscle stroma is there. Abundant stroma is there. But in case of carcinoma prostate, there is scanty stroma, and this stroma is infiltrated by these malignant cells. So glandular pattern, basing on this glandular pattern, if there are small or medium-sized glands lined by a single layer of cuboidal or columnar epithelium, it is a well-differentiated adenocarcinoma. If there are small or medium-sized glands lined by a single layer of cuboidal epithelium, normally in the prostate the epithelium is bilayered. The lower layer is a basal layer, which is cuboidal, and the innermost layer is a columnar epithelium which secretes mucin. So in the prostate, the acini are lined by two layers. Towards the basal membrane, there is a cuboidal or flat basal cell layer, and towards the lumen there is a columnar mucin secreting epithelium. But in case of prostatic carcinoma, there is only one epithelial layer, cuboidal or columnar epithelium, and there is absent basal cell layer. The prostatic carcinoma, there is absent basal cell layer. So in a well-differentiated carcinoma, the glandular pattern is present. In moderately differentiated carcinoma, there is cribriform pattern, sieve-like pattern is there. In poorly differentiated carcinoma, only sheets of cells are there. There is no glandular differentiation. So basing on the tendency to form basing on the architecture, this well-differentiated, moderately differentiated, poorly differentiated is given. If there are well-formed glands lined by a single layer of epithelium, absent basal cell layer, it is well differentiated. If there is a cribriform pattern, there is no glandular appearance, it is a moderately differentiated. Only sheets of cells are there, there are no alveoli, there is no acinar pattern, then it is a poorly differentiated carcinoma. The tumor cells are large. The tumor cells are different from the normal prostatic cells. The tumor cells are slightly larger, and there are no clear-cut features of atypia. There is mild atypia is there. The tumor cells are large, and the cytoplasm may be clear, or it may be dark basophilic, or it may be eosinophilic with granular cytoplasm. And they show varying degrees of anaplasia. The nuclear atypia is usually mild, slight. So the one important feature of malignancy is intraprostatic perineural spread. Perineural spread within the prostate. It is a clue to the diagnosis of prostatic carcinoma. Within the prostate, there are some neurons, and in these neurons, there is around these neurons there is a spread. That is, this gives a clue that this is a prostatic carcinoma. Prostatic perineural invasion is a clue to the diagnosis. Intraprostatic perineural invasion is a clue to the diagnosis. So this is a PIN. PIN stands for prostatic intraepithelial neoplasia. Benign glands having intra-acinar proliferation and nuclear anaplasia. They are widely separated with large branching glands with papillary infolding. There is the difference between PIN and prostatic carcinoma is in PIN, the basal membrane is intact. The basal membrane is intact in PIN. Whereas in prostatic carcinoma, the basal membrane is breached. There is invasion of the malignant cells into the adjacent stroma, that is invasive carcinoma. Whereas in PIN, the basal layer is intact basal membrane, and the presence of basal cell layer is the difference between PIN. Whereas in invasive carcinoma, there are no basal cell layer and the basal membrane is also breached in case of prostatic carcinoma. So there is some grading. Gleason's grading is used for the grading of the prostatic carcinoma. So the scores are given 2 to 10. So on the microscopy, the architecture is taken into consideration. If there is a gland pattern, based on the architectural patterns, there is a primary pattern and there is a secondary pattern. The predominant pattern in which the tumor is present is called the primary pattern. So if there are predominantly glands with atypia, then it is given 1 plus. 1 point is given. If only sheets of cells are there, then it is given 5. So in between few glands, then it is given 2, 3, 4 like that. So the primary pattern and the secondary pattern, both are added together, then we will get the score. So if both the primary and the secondary patterns are both the glandular pattern, only glandular pattern is there, then the score is 1 plus 1, 2. If only the sheets of cells are there, there is no glandular pattern, then the score is 5 plus 5, that is 10. If the predominant pattern is glands and some few sheets are also there, then it is 2 plus 5, the score is 7. So that is Gleason's scoring. This is the staging. Staging T1 means incidentally found resected specimen, that is T1. T2 means the carcinoma is confined to the organ. T3 there are A and B. B means seminal vesicle invasion is there. A means without seminal vesicle. Extra prostatic extension without seminal vesicle invasion is 3A. 3B means with seminal vesicle invasion. T4 is the direct invasion of contiguous organ. N1 nodal metastasis is there. M1 is the presence of distant metastasis. So that is the stage. So clinical course. The incidence increases with the advancing age. Clinically advanced tumors have urinary symptoms. So this one is given usually as a multiple choice question. So the metastasis in carcinoma of the prostate are osteoblastic metastasis. The metastatic deposits in carcinoma of the prostate are osteoblastic. Another one is the lumbar metastasis. The spinal metastasis are seen in prostate. Thyroid also, the cervical metastasis is seen. Cervical vertebrae metastasis involvement is seen. In prostate also, there is a lumbar spinal involvement, vertebral metastasis. So PSA stands for prostatic specific antigen. PSA is a tumor marker. So tumor markers are not the primary modalities of diagnosis. They have an adjuvant role. They have a supportive role. So on biopsy, we got a prostatic carcinoma report. So to further confirm whether it is a carcinoma or not, we can do the PSA levels. So PSA levels greater than 4 nanograms per liter is abnormal. PSA levels greater than 4 is an abnormal, but there are some age specific reference values because PSA increases with the age. There is no specific PSA for all the ages. PSA value increases with the age correspondingly. So for an individual, the upper between 40 to 49 years of age, the upper limit is 2.5 nanograms per ml. For an individual between 50 to 59, the upper limit is 3.5 nanograms per ml. For an individual between 60 to 69, the upper limit is 4.9 nanograms per ml. For a 70 to 79-year-old individual, the upper limit is 6.5 nanograms per ml. So normally, so these are the age-specific reference values. So for a 40-year-old individual, 4 nanograms is slightly abnormal. 4 nanograms greater than 4 is abnormal. So serum PSA levels greater than 4, they are not diagnostic, but they are abnormal. So PSA is not cancer specific, it is organ specific. PSA, prostatic specific antigen, is not cancer specific. Increase in the PSA does not mean there is carcinoma of the prostate. There is some abnormality in the prostate. It may be benign prostatic hyperplasia, it may be prostatitis, it may be infarction in the prostate, or it may elevate even because of instrumentation, some catheterization, cystoscopy. They can also elevate the PSA, prostatic specific antigen. Even ejaculation can also increase the PSA. So PSA, increase in the PSA is not diagnostic of prostatic carcinoma. It has only an adjuvant role in the diagnosis of prostatic carcinoma. So 20 to 40% of the patients with organ confined prostate cancer have less than 4 nanograms per ml. So sometimes the PSA value is less than 4. So even then there may be a carcinoma of the prostate. So the other values, the other things which may help in the diagnosis of the prostatic carcinoma, PSA density, PSA velocity. Velocity means for every 6 months you will check the PSA values. If there is drastic increase in the PSA value, then it is a suspicion. So there are age reference values, just now it is over. And the ratio between the free and the bound PSA. All these things will also help in the diagnosis of prostatic carcinoma. So the early detection of prostatic carcinoma is by rectal examination, transrectal ultrasonography, and the serum PSA values. These help in the early detection of the prostatic carcinoma. Early detection of prostatic carcinoma is by rectal examination, transrectal ultrasonography, and serum PSA values. So PSA is also used to assess the response to therapy. So after doing prostatectomy, the PSA should fall down. But if the PSA is even elevating, means there is some cause of this tumor inside the body. So it also helps to assess the response to therapy. So that is about the PSA. So the treatment of prostatic carcinoma is surgery, transvaginal resection of the prostate, radiotherapy, and hormonal therapy. Hormonal therapy means depriving the tumor cells of the tumor cell growth by depriving of testosterone. That is orchidectomy is done. This can be achieved by doing orchidectomy and estrogens. So that is hormonal therapy. So in a case of the carcinoma of the prostate, transurethral resection of the prostate is done. Radiotherapy is given, and to deprive the tumor cells from proliferating, the testosterone is deprived by removing the testis. Orchidectomy is done, and administration of estrogens. That is a hormonal therapy in case of carcinoma of the prostate. So next coming to the testis and epididymis. So what are the contents of the scrotal sac? The scrotal sac contains the testis, epididymis, the lower end of the spermatic cord, and the tunica vaginalis. These are the contents of the scrotum. The scrotum contains the testis, the epididymis, the lower end of the spermatic cord, and the tunica vaginalis. So the epididymis is attached to the posterior end of the to the body of the testis posteriorly. The testis and the epididymis are together considered as one organ. That is why there is epididymo-orchitis. So testis and the epididymis are together considered as one organ. Histologically, the main components of the testis are the seminiferous tubules. There are plenty of tubules lying via basal membrane. So the seminiferous tubules, they contain a lamellar concrete tissue, which is a membrane and contains several layers of cells. The testis consists of seminiferous tubules. Plenty of seminiferous tubules are there. So in these seminiferous tubules, they contain a basal membrane, and several layers of cells are there in the seminiferous tubules. These layers of cells are of two types. One is a spermatogonia, and another one is a serotoli cells. So in the seminiferous tubules, there are two types of cells: the spermatogenic cells and the serotoli cells. The spermatogenic cells are the germ cells, so which produce the spermatocytes, spermatozoa and spermatids. So the seminiferous tubules also contain serotolin cells. The serotolin cells, they provide support. They are supportive to the germ cells. They produce estrogens and androgens. The serotolin cells, they produce estrogens and androgens. So the fibromuscular stroma in between the seminiferous tubules contain interstitial cells of leading. These leading cells have abundant cytoplasm containing lipid granules and elongated rinky crystals. So these leading cells are the main source of testosterone and androgen in case of males. So the testis contains plenty of seminiferous tubules, and these seminiferous tubules will have a basal membrane, and inside the seminiferous tubules there are two types of cells, the spermatogonia and the sertoli cells. The spermatogonia, they give rise to the spermatozoa and the spermatids. The sertoli cells, they are larger cells, they support the spermatogonia, and they also produce estrogens and testosterone. So outside the basal membrane of the seminiferous tubules, there is a fibrocollagenous stroma. This fibrocollagenous stroma contains leading cells. The leading cells are large cells. They have vacuolated cytoplasm, and they contain lipid granules and the rinky crystals. These leading cells are the source of testosterone and androgens in males. So serotonin cells and the leading cells are the counterparts of the granulosa theca cells in females. In females, there are granulosa theca cells which produce estrogens. So the serotonin cells and the leading cells, they are the counterparts of the granulosa and theca cells in the females. So the leading cells and the serotonin cells, they produce the testosterone androgens. So the next topic is so today we'll be talking about the testicular diseases. The first one is cryptorchidism. So cryptorchidism is an undescended testis. Cryptorchidism or undescended testis is a condition in which the testicle is arrested at some point of its descent. So cryptorchidism, cryptos means hidden. Cryptos means hidden. Orchidism means testis. So cryptorchidism or undescended testis is a condition in which the testicle is arrested at some point of its descent. So the incidence is about 0.2% in the adult males. 70% of the times the testis is the arrest occurs in the inguinal ring, and another 25% of the cases the testis is seen in the abdomen, and another 5% of the cases anywhere along its descent. So 75% of the cases the testis is arrested in the inguinal canal. Another 25% of the cases the testis is present in the abdomen, and another remaining 5% anywhere along its descent. So the etiology, what is the cause of cryptorchidism? The exact cause of the cryptorchidism is not known, but a few factors play a role. One is mechanical factors. When the spermatic cord is very short, the testis may not descend. When the inguinal canal is very narrow, then also the testis is not able to descend. When there are adhesions between the testis and the peritoneum, there may be failure of descent of this testis. So the mechanical factors are short spermatic cord, the inguinal canal is narrow, or there are adhesions with the peritoneum. The testis and the peritoneum are adhered. So these are the mechanical factors. Genetic factors are Klinefelter trisomy 13 and maldevelopment of testis or cremaster muscle. These are the genetic factors. Hormonal factors are deficient androgenic secretions. These are the factors. So pathologic changes. In most of the cases, the cryptorchidism is unilateral, but in 25% of the cases, it may be bilateral. Grossly, the cryptorchid testis is small and firm. The cryptorchid testis is smaller and fibrotic. Histologically, the seminiferous tubules show a thickened basal membrane. The basal membrane are of the these are all the seminiferous tubules. So the basal membrane, you can see a thickened basal membrane. There are no spermatogenic cells over here. So thickened basal membrane of the seminiferous tubules with few or no spermatozoa. So sometimes very few spermatozoa are there. Here you can see very few spermatozoa, and here the spermatozoa are absent. So thickened basal membrane and very few germ cells, spermatozoa, and no spermatozoa. Only basal membrane is there, and the spermatogenic cells are not seen. And in advanced cases, there is hyalinization of the basal membrane, and only few Sertoli cells are there. In advanced cases, there is hyalinization of the basal membrane, and only few Sertoli cells are there. So interstitial stroma is increased with the conspicuous presence of leading cells. So this is the interstitial stroma. In the interstitial stroma, some few interstitial cells of leading clusters or individual cells are seen. So in a Cryptorchid testis, there is a thickening of the basal membrane of the seminiferous tubules. In advanced cases, there is hyalinization. There are very few spermatogenic cells. There are no spermatozoa, and few Sertoli cells are there inside. And in the connective tissue, there are scattered leading cells or small clusters of leading cells. That is a microscopy. So absent development of germ cells, there are no germ cells. The hyalinization of the basal membrane is thickened, and in the interstitial connective tissue stroma, there are prominent leading cells. That is the microscopy of the Cryptorchid testis. So in advanced, so clinical features in the Cryptorchid testis, when the scrotum does not show testis in a child when less than 2 years of age, a correction must be done before 2 years of age. Otherwise, significant adverse outcomes may occur. So when the scrotum sac does not show testis, the surgical correction must be done within 2 years of age, because if it is not done within 2 years of age, the outcome will be adverse outcome will occur. So if the descent does not occur, he may land up in sterility or infertility. Sterility when both the testes are not descended. If there is one testis is descended and one testis is Cryptorchid, then infertility occurs. Sometimes there may be a inguinal hernia. A concomitant inguinal hernia is usually seen with Cryptorchid testis, and the risk of malignancy in a Cryptorchid testis is high, 35 times more common. The tumor, the testis which has not descended, the incidence of seminoma and the embryonal carcinoma, the malignant testicular tumors, the incidence, the risk increases by 35 times. So the risk of malignancy increases by 35 times in the case of undescended testis. The tumors which occur in undescended Cryptorchid testis are seminoma and embryonal carcinoma. So next, coming to the male infertility. So male infertility can be because of pre-testicular causes, testicular causes, and post-testicular causes. The infertility in the case of males may be due to pre-testicular causes, testicular causes, or post-testicular causes. The post-testicular causes are obstruction, block, congenital block, or acquired block in the vas deferens. Congenital block in the vas deferens, acquired block because of surgery or vasectomy, because of surgery, because of gonorrhea, there is an acquired block in the vas deferens, or impaired sperm mobility or rheumatoid cilia syndrome. All these are the post-testicular causes. The post-testicular causes of infertility in males are block, congenital block or acquired block. Acquired block is because of surgery or gonorrhea, rheumatoid cilia syndrome, and impaired sperm motility. These are the post-testicular causes. The testicular causes are agonadism, cryptorchidism, maturation arrest, hypospermia, Sertoli-Olney syndrome, Klinefelter syndrome. These are the testicular causes. The testicular causes are cryptorchidism, agonadism, hypospermatogenesis, Serotoli-only syndrome, Klinefelter syndrome. These are the testicular causes of male infertility. So the pre-testicular causes of male infertility are endocrinal causes like hypopituitarism, estrogen excess, glucocorticoid excess, or sometimes endocrine disorders like diabetes mellitus and hypothyroidism are also responsible for male infertility. Male infertility is because of three reasons: pre-testicular causes, testicular causes, post-testicular causes. The pre-testicular causes are endocrine causes: hypopituitarism, estrogen excess. Estrogen excess means endogenous excess from hepatic cirrhosis, adrenal tumor, septolytic cell tumor, or these are the estrogen excess, or glucocorticoid excess. Endocrine disorders like diabetes mellitus and hypothyroidism are also responsible for the pre-testicular causes of male infertility. The testicular causes are agonadism, cryptorchidism, Klinefelter syndrome, Serotoli-only syndrome, and hypospermatogenesis. The post-testicular causes are congenital block, acquired block. Acquired block is because of surgery or because of gonorrhea, and impaired spermatozoa in case of impairment of motility, sperm motility in case of immotile seizure syndrome. So these are the causes of male infertility. So next, coming to the inflammation. Inflammation of the testis. So inflammation of the testis is called orchitis. Inflammation of the epididymis is called epididymitis. So epididymo-orchitis, because testis and epididymis are both considered as one organ, it is usually referred to as epididymo-orchitis. Epididymo-orchitis. So the non-specific epididymo-orchitis, it may be acute or chronic. The most common routes of spread are via the vas deferens, or sometimes there may be lymphatic spread of the infection or hematogenous spread of infection. The most common organism in case of sexually active men is less than 35 years is Neisseria gonorrhea and Chlamydia trachomatis. These are the most common organisms in a sexually active man. The most common organism responsible for the epididymo-orchitis in less than 35 years of age in a sexually active man is Chlamydia trachomatis and Neisseria gonorrhea. In old man, the epididymo-orchitis is because of E. coli and Pseudomonas. In older people, it is because of E. coli and Pseudomonas. The histologic changes, the pathologic changes. In the acute stage, the testis is firm, it is tense, swollen, and congested with multiple abscesses. In the acute stage, the testis is swollen, tender, tense, with multiple abscesses. In the chronic stage, there is variable degree of atrophy and fibrosis. In chronic stage of epididymo-orchitis, there is variable degree of atrophy and fibrosis. Histologically, in the acute stage, there is congestion, edema, infiltration by neutrophils, lymphocytes, macrophages, plasma cells, and the formation of neutrophilic abscess. In the acute stage, there is congestion, edema, there is testis is infiltrated by acute inflammatory cells, the neutrophils, and there is a neutrophilic abscess. In the chronic stage, there is disappearance of the seminiferous tubules, there is fibrous scarring, and there is a destruction of the Leydig cells leading to permanent sterility. In the chronic stage, epididymo-orchitis, there is a disappearance of the seminiferous tubules, there is fibrous scarring, and destruction of the Leydig cells leading to permanent sterility. So there is one entity known as granulomatous orchitis. In granulomatous orchitis, it can be of two causes: tuberculous granulomatous orchitis and a non-tuberculous granulomatous orchitis. So non-tuberculous granulomatous orchitis is a painless unilateral enlargement of the testis in the middle age. The non-tuberculous epididymo-orchitis, the etiology is not known, but histologically there is a non-caseating granulomas with lymphocytes, plasma cells, neutrophils, and multinucleated giant cells. In tuberculous epididymo-orchitis, it may be primary or secondary. Primary rarely occurs. Tuberculous epididymo-orchitis, orchid is rare. Primary genital tuberculosis is very rare. So this secondary tuberculosis is more common. Secondary tuberculosis is occurs because of spread of genitourinary tuberculosis. Spread of genitourinary tuberculosis with tuberculous seminal vesicleitis, tuberculous prostatitis, or renal tuberculosis spreads to the testis. That is called tuberculous epidermolysis. So tuberculous epidermolysis is secondary to genital tuberculosis. Grossly, there is a macroscopically in tuberculous epidermolysis, there are discrete yellowish gaseous necrotic areas. Microscopically, there is necrotic foci, and AFB, acid fast bacilli, can be demonstrated in these epidermolysis by ZM stain, Ziehl-Neelsen stain. So the lesions can be the lesions can cause extensive destruction of the epidermis and may cause chronic discharging sinuses of the scrotal skin. So tuberculosis, chronic discharging sinuses are seen on the scrotal skin. Chronic discharging sinuses on the scrotal skin are seen in case of tuberculosis. So there is another granuloma called spermatic granuloma. Spermatic granuloma when there is injury to the testis. These spermatozoa, they enter into they invade into the stroma. So spermatic granuloma is a development of the inflammatory lesion due to invasion of the stroma by spermatozoa. It may be due to trauma or following inflammation or loss of ligation of the vasectomy. There is a spermatic granuloma formation. Spermatic granuloma formation is because of the invasion of the interstitial tissue, invasion of the stroma by the spermatozoa. Spermatozoa invasion will occur when there is injury to the testis, or when there is a inflammation, or when there is a loss of ligation following vasectomy. This spermatic granuloma is about 3 millimeters to 3 centimeters in diameter, and it is yellowish. And under the microscope, in the center of the granuloma, there are spermatozoa along with the necrotic debris. That is a spermatic granuloma. Next one is elephantiasis. So elephantiasis of the scrotum, elephantiasis of the leg is seen in filariasis. So elephantiasis is enormous thickening of the scrotal skin resembling elephant's hide and results from enlargement of the scrotum. Elephantiasis is enlargement of the scrotum, enlargement and thickening of the scrotal skin resembling elephant's hide and results from enlargement of the scrotum. So this elephantiasis results from obstruction of the lymphatic duct by the adult Wuchereria bancrofti. Adult Wuchereria bancrofti, it will cause obstruction of the lymphatic duct. So the patients present with fever, local pain, swelling, rash, tender lymphadenopathy, and blood eosinophilia. Grossly, the affected leg or the scrotum is enlarged enormously with enlargement of the lymph nodes. The dermal lymphatics are also dilated. So sometimes granulomatous reaction is seen in advanced cases, chronic lymphedema. There is subcutaneous fibrosis, epidermal hyperplasia develops. This is called elephantiasis. Sometimes there is a granulomatous reaction is seen. In advanced cases, chronic lymphedema, there will be subcutaneous fibrosis, epidermal hyperkeratosis develops. It is termed as elephantiasis. So there are some miscellaneous lesions in the testis. The torsion of the testis, varicocele, hydrocele, heptocele. So these are the miscellaneous lesions. Torsion of testis, sometimes undescended testis may undergo torsion suddenly. This causes a cessation, results in a cessation of the venous drainage and the blood supply. Because this occurs because of sudden muscular effect, because of physical trauma. So the testis will undergo necrosis and hemorrhagic infarction. Torsion of testis is because of sudden muscular effect. So there is obstruction to the outflow or cessation to the venous drainage. This causes hemorrhagic infarction of the testis and it undergoes necrosis. That is torsion of testis. Varicocele. Varicocele is the dilatation and elongation and tortuosity of the pampiniform plexus of the veins in the spermatic cord. Varicocele is dilatation, elongation, and tortuosity of the pampiniform plexus of the veins in the spermatic cord. Varicocele is dilatation, elongation, and tortuosity of the veins in the spermatic cord is called varicocele. So hydrocele is the accumulation of the serous fluid in between the two layers of the tunica vaginalis. Tunica vaginalis is present around the testis. So when there is fluid accumulation in between the two layers of the tunica vaginalis, it is called hydrocele. So hydrocele may occur because of trauma, because of cardiac failure, because of renal disease, or sometimes because of syphilis, gonorrhea, tuberculosis. So these are the various causes. Usually the sac is unilocular, sometimes it may be multilocular. So the wall of the sac is composed of fibrous tissue. It's mild infiltration by lymphocytes and plasma cells. Hydrocele is accumulation of the fluid in the tunica vaginalis. It occurs because of trauma, because of infection with tuberculosis, gonorrhea, or syphilis. Sometimes it may be because of cardiac failure or secondary to renal disease. So the hydrocele is usually a unilocular, sometimes it may be multilocular. The hydrocele sac contains fibrous connective tissue with mild infiltration by the lymphocytes and plasma cells. Hemtocele is because of rupture of one of the blood vessels in the testis. So hemorrhage into the sac of the tunica vaginalis may result from direct trauma or by injury of the vein by a needle or bleeding disorders. So hemorrhage into the sac of the testis of the tunica vaginalis is called hemtocele. Hemtocele is because of injury to the vein by a needle, or because of bleeding disorders, or because of a result of injury to the testis. So microscopically, there is a mass of clotted blood with fibrin in the walls. In advanced cases, there is a thickened wall with dense fibrous tissue. So that is about the lesions in the testis. So tomorrow I will be talking about testicular tumors. We will see in the next class. Thank you.